Welcome, everyone. Thanks for joining today's call. My name is Audrey Bell. I'm Kristen Waller's assistant here at the American Heart Association. All attendees are placed on mute. If you have a question, please type your question in the chat or Q&A box to the right of your screen. Today's presenters include Allison Capetillo, Quality and Systems Improvement Director, Deb Moats, Senior Director of Quality and Systems Improvement, and then Kristen Waller, Quality and Systems Improvement Director. So now I will hand it off to Allison.
Good morning, everyone. Can everyone hear me okay? Kristen, can you give me a heads up if you can hear me?
Yes, we can hear you.
Perfect. Okay, well, good morning.
Hey, it's Kristen. I'm sorry, I couldn't come off mute. If you don't mind, I'll start. Is that okay? And then
you
I'll
want to start? I didn't know if you wanted me to introduce. Did you want me to introduce myself or no?
Yeah, you can go ahead. Sorry about that. I just couldn't come off mute.
Yeah, no
worries.
No problem. Well, I'll just do a quick. I just wanted to say hi to everyone on the call. Thank you all so much for joining us, and I'm going to be really quick and let Kristen take over. Thank you all so much for joining us. And I know we've probably met a lot of you on our tour of Arkansas. We're going to have a quick call with you all today and get to know everybody again and share some really great information. I got to meet some of you last year and talk with you all about Go with the Guidelines Stroke. So you might have met Deb and me. But for those of you who have not, my background is in stroke. I was a stroke coordinator in Houston, Texas. In my past life before I started with American Heart Association. I worked in a large comprehensive stroke center, so that is my passion and my background. I've also been a neuro-intensive care nurse, and so I love it. It's what I've done for a long time, and I'm definitely here to help and be a resource for you guys. So I will pass it back to Kristen.
Okay, I'm going to share my screen again, and you'll let me know. Can you see my slides?
Yes.
Yep.
Okay. We'll go ahead and get started with announcements today. I am Kristen Waller. I'm the Quality and Systems Improvement Director and cover the state of Arkansas and Atlanta and Texarkana, Texas. I've been a nurse for 15 years, and a lot of you probably met me during the boot camp where we traveled across the state or when I've come to visit at your hospital or the stroke task force meetings. So I just want to start with announcements as we still have some joining the WebEx now. Next week, we will send out snapshot day-to-days reports of your 2019 data that you've entered as of January 1st. So it's just a snapshot. It is not a final report. It may look similar to what I have up here on the screen. This is just a sample report. Those will go out probably midweek next week. And then we do ask that you have all of 2019 patient discharges entered by the end of February. That will give us a little bit of time to review your data and reach out to you with any fallouts that you may have before National Center pulls that data to review for recognition. So I do have around 75 hospitals in the state. So when everybody waits to the very last minute, it's difficult to help everybody out. So we do ask that you have all of your 2019 discharges entered by the end of February. And then you'll hear a lot from me during the month of March. Following that report, we will have a quality exchange for each of our modules. These slides will go out within a week, probably just a few days, along with a recording of today's webinar. But in the slides, there will be a link where you can go in and register for the quality exchange. So the one for Get With the Guidelines Stroke will be held on Tuesday, January 28th at noon. And we will review updates. We will also show you how to run patient level drill down reports So you can go into your data and see those achievement measures or quality measures that you're falling out on, and how to drill down into the data and make corrections if there's just an error in data entry into the registry. Last week I sent out an Arkansas Coffee and Quality with Kristen newsletter. Hopefully I'll keep this going every month, and we'll just give major updates, especially those that pertain to Arkansas in this newsletter. So some of you wear many hats, multiple hats at your facility. So not only are you doing stroke, but you're probably doing heart attack and heart failure and resuscitation and things like that as well. So this may be an easy way for me to get out just a brief update on all things in one email. We do have a heart failure conference coming up. It will be the first one for Arkansas. It will be held on February 6th. Registration starts at 7. The actual conference starts at 7:50 at the Clinton Presidential Center. And for $15, it includes breakfast, lunch, and continuing education. And I believe it's 10 hours credit there. So the link will be on this slide as well to register. If you want to share that with others in your facility, we'd appreciate that. And we have a full agenda, several physicians, EMS, nurses. We're covering lots of areas that day. I did want to mention the new voluntary public reporting option. Back in the fall, I believe it was October, and then again in December, your hospital, the key contact for your hospital, had the opportunity to opt in to public reporting. It is completely voluntary. You can opt out at any time, but going forward, there will be one opportunity a year to opt in. So the next opportunity will be for early spring, probably March, but we'll stick with early spring. An email will go out again to the key contact at your facility asking if you want to voluntarily opt into the public reporting. This will be for the public to go in and see how your hospital is performing. It will be in consumer-friendly language, easy for them to search by zip code, city, or state. And it will cover the achievement measures for whichever module you opt into. So if your facility participates in stroke, but also heart failure or resuscitation or coronary artery disease, you can select which modules that you want to publicly report. You do not have to do all of them. There is a minimum volume requirement of 30 records annually. If you are entering your entire year and you do not have 30 records, stroke patients that come to your facility, then as long as we have 6 patients in that measure, then we can work on that, on you being able to report. If not, it will just say that the criteria, the volume is too low to report. And this is what it looks like for the public, where they can just go in and enter a zip code, city, select the disease state. So, and then you'll see the achievement measures that would be listed. So if you have not opted in yet and you choose to do so in early spring, it will be on your 2019 discharges. That will be what's publicly reported. It will be numerator, denominator, and percentages. There were some updates, 2019 updates to the 2018 guidelines for stroke, and those were released on October 30th, and the links are provided to those as well, the top things to know, and then the full article. Okay, and we'll go ahead. We're done with announcements. Just a reminder, if you have any questions, you can type those in the chat box, and we'll get those to at the end of the presentation. So today, our objectives are to build on the November 2018 Get With the Guidelines Stroke virtual training and the 2019 Get With the Guidelines Stroke Abstractor Boot Camp that we held in Little Rock, Fayetteville, Jonesboro, and El Dorado. We want to review the history of the Arkansas form that was created for the Arkansas Department of Health and the Arkansas Stroke Registry. and I'll just go ahead and give a little background on that. I believe it was back in July of 2018, the health department requested that an Arkansas layer be created, and that would allow them to capture stroke bands, and also EMS agencies that pick up the patient in the field, and then a separate agency that transports the patient to a higher level of care. So there were just a few things that were added to the Arkansas form, the main thing being the stroke bands, and then also being able to track a patient from start to finish. So if someone picked the patient up in the field and transferred them to a rural hospital, and then a different EMS agency picked them up and transported them on to a higher level of care, then they would be able to capture all of those elements within the registry. And that stroke band, too, would be recorded by each EMS agency or hospital touching the patient. And so that would allow the health department to connect the dots behind the scenes and tie that patient together so it's viewed as one patient instead of possibly, 4 different patients. Today, I'll show you how to run the stroke band reports that are now available. We've been collecting the stroke band data for a little over a year, and now we can run reports on those. Arkansas regional benchmarks are being created. They are not available just yet, but they will be soon, and they will follow your trauma regions. So whatever the name of your trauma region is, which should also be your stroke and your STEMI region as well. And then we'll clarify the patient population for registry inclusion, discuss ICD-10 codes, and discuss the 5 data elements that fell below 95% with the 5-chart re-abstraction that was done by American Data Network for the Arkansas Department of Health. And then we've already provided the links to the 2019 guideline updates. So one of the updates with the stroke band in the past, you were to enter a stroke band ID, which starts with the letter S and then is followed by 6 numbers. And then you have the option to select not documented or not available. And I think that not available confused people because they didn't really understand why that was there. And it was there if you were entering a chart and you couldn't find your EMS record. And so you just didn't have it available at the time, but you were still looking for it. So that option was there for that purpose. But it has since been removed, so you either have a stroke band ID that you can enter or you have to select not documented. When you pull up your patient grid, you should be able to see a patient ID and a stroke band ID beside it as well. Or when you're pulling up patient level reports, then it will show up with a stroke band ID or stroke band ID not documented. It will have a check. It will say checked if they did not have one. Under configurable measures reports, this is where you can run your stroke band ID reports. You'll enter the time frame that you want if you want to run an annual report, and then you'll scroll down under your standard measures and look for the report that says stroke band ID documented, and then you'll click on that. Now you have to have the Arkansas layer in order to run this report, and all hospitals in Arkansas should have had that turned on. If you notice at some point that it's disappeared or it's not on for your facility, if you'll just reach out to me or to Quintiles IQVIA, and we can get that turned on quickly. So this is what the report will look like when you run the report. It will have a bar graph for those that have the stroke band ID that's present, or if it's not present. So you can tell just from this demo site that there were 22 opportunities, and 20 patients had the band, so that's 90.9%, and then 2 patients did not have stroke band documented, so that's 9.1% for your hospital. Now, any patient that goes into the registry should have a stroke band because the health department has requested that EMS place a stroke band on any suspected stroke out in the field. So even if it winds up being a TIA, they still should have had a stroke band placed. If EMS forgets to put one on, we ask that your emergency department place the band. Just at any point, you realize that there's no band placed, you should place a band on that patient and document it. You can also do patient-level drill down with this report. So you would go back out, you'd set your time parameters, select stroke band ID, and then under format, instead of the bar chart, you could select patient records. And so that would pull up a spreadsheet of all of your patients and provide a link where you could go into that patient record and look at it if you'd like. And you could know exactly, which patients did not have a stroke band. There's also a measure description for the stroke band report that's been added. It's a PDF. It's called Measure Descriptions Arkansas. And this is what it looks like. It was updated in November of 2019. So it just lets you know that it's all patients 18 or older, and that's what goes into the registry. It includes all the patients in the initial patient population. It will exclude any patient that was admitted for the sole purpose of elective carotid intervention. But other than that, everything else is included. There are no exceptions. And then it will break it up into there is a band or there's not a band. And as I mentioned, the Arkansas regional benchmarks will be available soon. It will begin with AR and then followed by the name of your trauma region. And so here's just a sample. If I wanted to compare my hospital to the Arkansas Valley region, if that's the region that I'm in, I could compare to all Arkansas hospitals, all hospitals. You could compare to the Arkansas Department of Health. So as you know, if you're participating in the Arkansas Stroke Registry through the Arkansas Department of Health, they use Get With The Guidelines Stroke. But there are additional hospitals other than Arkansas. So you have some in bordering states that participate as well because we feed patients into them due to their location. So you would be able to just control click and select multiple things that you want to compare to. And then a bar graph will generate and it will show you how you're doing compared to your region or their state or to the hospitals in the health department. And now I'm going to pass it over to Allison. So give me just a second. I'm going to stop sharing my screen so that I can, or I'm going to give you control. Oh, do you have it, Allison?
This is Deb. This is Deb's section.
Oh, I'm sorry. Yes. Okay. Deb, I'm going to pass it over to you.
You may be able to keep control, though, and she may be able to just tell you to say next slide, unless she wants to share the slides on her own screen. I just thought of that.
Oh, Deb, do you have control? Can you advance, or you want me to advance? Hey, Deb, I think you're still on mute.
That help?
Oh, I can hear you now, Deb.
Okay. Okay. Yeah, Kristen, go ahead and run the slides for me.
Will do.
Okay. And so while she's pulling that back up, my little part here, I'm going to talk a little bit about the entry criteria, like what patients you should put in there, and then try to give you some information about the discharge diagnosis area versus the ICD-10 code. Okay, so go ahead, next slide. So we'll start with the final clinical diagnosis related to stroke. So that is actually located on the administrative tab, and that's where you see, you pull up your administrative tab, you see the final clinical dose, or diagnosis, related to stroke, and right below there are all the options that you have. So you choose as an ischemic, as a TIA, subarachnoid, intracerebral, stroke not otherwise specified, or no stroke-related diagnosis, or if it's elective carotid intervention only. So you choose one of those. This field is used, we use this field to define all of the Get With The Guidelines awards. So the stroke measures, this includes all stroke and all TIA patients for this final clinical diagnosis. So you should always choose something in that area about as far as what your clinical diagnosis is in order for your achievement award measures to run appropriately. So this field here is only used for stroke award and for target stroke status only. Next slide. So, the next tab would be the clinical codes tab, and that is, if you can see up here on the top, I'm sure you can't see it, but it's demographic, administrative, and then the clinical codes. So this is where you enter the ICD-10 code. The ICD-10 code, where it says principal diagnosis code, that's actually your discharge diagnosis code. So whatever your primary discharge diagnosis is what you would enter into that particular field. The codes are there. You can add codes. You know, you can use a quick pick. You can in this particular one for Arkansas, you can put any code you want in there. It's not. It's got. I mean, as far as the stroke codes, any stroke code that is available and is approved, you can put in there. This code, what they use for this one, the ICD-10 code for, is this is the one that they use when they're figuring the stroke measures for the Joint Commission. So if you have the STK layer or the CSTK layer, then you need to be able to fill in the diagnosis code, the ICD-10 principal diagnosis code. So that should always be filled in. Now that code should match whatever you fixed on the last slide, where it says the diagnosis for the administration tab, the diagnosis, that should match whatever your ICD-10 code is. Okay, so click it again, please. So when you're looking at the side here, over on the side where it shows clinical diagnosis, at the top is your ICD-9 and your ICD-10. And then below that is their principal diagnosis code. So if you're a comprehensive center or a thrombectomy center, then you should also be entering any principal procedures that you do. So if you would do a thrombectomy, IA or IV, TP, or alteplase, those codes go into that principal diagnosis code. So if you are at that level and you're Joint Commission certified, then you do fill that in. Otherwise, you don't need to fill that in. The main one you need to be concerned at this point is the ICD-10 principal diagnosis code. Right now, that is optional for most people, but for Arkansas, the research and the studies that they want to work on, they're based off of this ICD-10 code. So this code does need to be filled in. Now, if you look down below the red X here to the bottom of it, where it says discharge diagnosis, that's another one. That's a final discharge diagnosis code. Typically, people are not filling that, are not entering anything into that code because they already have their principal diagnosis code at the top. However, some of the researchers in Arkansas may want to have that discharge diagnosis as a bottom code filled in as well. We will let you know that at a later date, but at this point, make sure you do the ICD-10 principal diagnosis at the top of that clinical code, and you should be good for now. Next slide, please. So for Arkansas, like I said, you enter the diagnosis code that describes the stroke or TIA-related condition for this episode of care. So that's where your code comes from. What is for this episode of care, what is the primary stroke diagnosis or TIA? The code entered here describes the final clinical diagnosis. It says principal, that means the final clinical diagnosis related to the stroke selected on the administrative tab of the PMT. So again, that one you should fill in, that's where your awards come from. The allowable values for that, there's an ICD-10 CM, and there is actually a link here to that. That is the CMS government Medicare coding, and you can use anything on that code list, which isn't necessarily everything that's on the TJC manuals, which gets kind of confusing. So for stroke 4 measures, or the TJC, the bottom up half of the slide, for those patients, you use the ICD-10 code, and you need to make sure that ICD-10 code is on tables 8.1 or 8.2, and that's in the actual disease-specific measure certification manual for the Joint Commission. Can you click on that top one, Kristen, the TJC measure specifications manuals, and it should take you to that. So you can just take a look to see what you're going to see. Okay, so this slide will come up when you click on that, and you notice there it's got measure specification manuals. So this manual changes actually about every 6 months or so. There's things that are revised, not necessarily all stroke related, but oftentimes it is. But you see the future, which is coming soon. You'll see current, where it says specification manuals for Joint Commission national quality measures and the version, and it tells you the day that it's updated, and also tells you when it is effective. So when you see down below, it says this is for all discharges 1/1/20 through 6/30/20. So this is the first 6 months. This is where you would look to see what actually needs to be included in order for these patients to fit into those measures. Kristen, could you click on that where it says current? Click on the specification manual so you can kind of see, yeah. So when you click on this, then this opens up. And if you scroll down a little bit, this is all of the Joint Commission quality measures. But if you scroll down a little bit, first of all, you're going to see there's your acute stroke ready. So if you're thinking about going for certification for acute stroke ready, that's where you find the definition. So there's an inpatient and there's an outpatient measures that must be reported to Joint Commission if you are certified for acute stroke ready. And this is where you will find what those actually mean, what those are. Scroll down a little bit further and you can see the comprehensive STK measures. So each one of those measures, there's 1 through 12, and then a little bit further down, you'll go to stroke STK measures. And then, so just click on any one of those so they can see what that looks like. So this is what it'll look like. It'll tell you it's STK1, which is the VTE prophylaxis. And then when you go down, it'll tell you the data elements that is included. You have to have in the PMP in order for this to be calculated appropriately. So that's what all of these blue fields, the data elements. Now, if you need a little bit more explanation as far as what exactly does that mean, you can click on that data element and another sheet will come up to tell you exactly what you're looking for there. Okay, and so it tells you what's in the population. But just so you know, anything with the Joint Commission, anything for the certification, this is where you will get your definitions, and it will tell you exactly what you need. If you're not certified, you don't really need to worry about this. But if you go down, click back, go back one.
Click which one? I'm sorry.
At the top, go back up to the top and just hit back. Hit the back button up on the corner. Or go hit home.
Okay.
Yeah, that works. Okay, now scroll down again, way to the bottom. This is where you're going to find all of your codes. So if you go all the way, there you go, the appendices. So A is your code table. So if you click on that, that's where you're going to find your table 8.1. It's ischemic stroke. So that will have the table of all measures that your code has to be one of these codes in order to calculate in that measure. There's a few codes that are a little bit different and they won't calculate appropriately, but that was just recently updated. But this is all of the codes there. If you go down a little bit further on here, there's the 8.1. That's going to tell you your thrombolytic. So if you give IV PPA, then it would be introduction of the thrombolytic interperipheral vein, percutaneous approach. So that's where your code would come from that. If you gave IV PPA or if you gave IA PPA, then there's the code for that as well. Then if you go on, if you're comprehensive or thrombectomy capable and you do some of the endovascular procedures, then that's what the the thrombectomy procedures. So up just a little bit. So this is when they actually are able to open up the vessel. Then you use one of those codes. I hope this is making sense. And then if you go down a little bit further and say that they've entered the vessel, they've done the actual puncture, but they were not able to actually pull the clot, they were not able to reperfuse it, then you use one of these thrombectomy root procedures, and that way everything that needs to calculate will calculate correctly. But again, these codes and these tables are only for the Joint Commission certified centers. So yeah, we can go back to slide presentation now. Any questions from anybody at this point on that? That gets kind of confusing.
We do have one question, Deb, from the group. It says, if an audience selects ischemic stroke as the final clinical diagnosis related to stroke, does that mean the only ICD-10 codes that would be permissible to choose would be codes that would be for ischemic stroke? I wonder if there are any checks. And I think I can answer, but I'll let you answer if you'd like to.
Yeah, I think so. What you're asking is the ICD-10 code. I'm sorry. Go ahead and answer it. I think without seeing it.
The best answer I have is there aren't any limitations necessarily because they're not mutually exclusive. The drop-down feature is not tied directly to the clinical code that's entered by the abstractor. They're separate. So the clinical code can be entered manually. However, on the back end, when there is research done at the national level or even at the regional or state level for that matter, say for example, there's a research proposal put in through our national center that goes through Get With the Guidelines and it gets approved. That research proposal then the data would probably be cleaned through Duke Clinical Research. And in that case, I would imagine they would have to do some kind of check to make sure there's not going to be data that comes out where it would be, I would think, mismatched like that. I don't think that they would have a bunch of data coming out where we'd have, intracranial hemorrhages mismatched with clinical codes that are not for intracranial hemorrhage, if that makes sense. I hope that helps answer that question.
Yeah, so go back one more, Kristen. So that one. So the final clinical diagnosis code, this one here that you use on the admin tab, is used for awards. That's the only thing that's really used for is for the awards, the final diagnosis, but it should match. Now hit the next slide, the clinical codes. So for that last one, it was an ischemic stroke, and then where you see where it says ICD-10 principal code, it says cerebral infarct due to unspecified occlusion. So there again, that should be an ischemic stroke ICD-10 code. You should not have a hemorrhagic intracerebral hemorrhage or a subarachnoid hemorrhage, non-traumatic. You should not have a code like that in there. It should match whatever your administrative one is. And again, the clinical codes on this particular slide, that's the ones that are used for research purposes. So please fill that first ICD-10 code for the principal diagnosis code, which is the final diagnosis code, discharge diagnosis code. Does that make sense? Does anybody have any questions about that?
This is Kristen. I just wanted to clarify too that as far as the ICD-10 codes, if you are a drip and ship hospital, if you're not Joint Commission, Primary Stroke Center, Comprehensive, or Acute Stroke Ready through the Joint Commission, you can use those ICD-10 codes, whichever ones that your hospital uses. You are not limited to the Joint Commission table of ICD-10 codes. As long as it's stroke related, right, you're not limited.
Right, that's correct. All right, so we'll go on to back to where we left off.
Yeah, we have a question from Robin.
Okay.
Just for patients who have a bleed during their hospital stay, but was not the principal discharge diagnosis code, are we still putting those in the registry? Example, patient presented with a STEMI and treatment for STEMI was given during the stay, but patient had a stroke bleed for a secondary diagnosis.
Okay, so that actually is up to you. That would be considered an in-house stroke. A lot of hospitals, yes, are keeping track of their in-house strokes as well. And so the principal diagnosis on that particular patient would be the STEMI code, whatever the STEMI code is. And then your secondary diagnosis would be hemorrhagic. Now, you would be able to run some reports on your inpatient stroke patients. However, when you run them for like the Joint Commission and for the awards and that kind of thing, those patients are excluded. They're not part of the actual, of those performance measures. Did that answer your question?
I will wait for a response from Robin. And then she had a secondary question as well. And then she says, if the patient receives TPA, should we be using that code instead of the ischemic stroke code?
So if they receive TPA, then you use the ischemic stroke code first as your ICD-10 final diagnosis code. And then under procedure, the ICD-10 procedure code is where you would add that IVTPA administration. That would be considered a procedure.
She says, Robin says, thank you.
You're welcome. You're welcome. Okay, so we'll go on to the next slide. Oh, go ahead.
Lindsay has a question, but I don't think it came through. So Lindsay, if you have a question, will you type it in the chat box? I just wanted to let her know that it didn't come through.
Okay.
Okay, thanks.
Yep. And so then just to quickly try to verify for you guys. I know it does get confusing, but the procedure codes that they use are for actual procedures. So they're required only for the comprehensive or the Joint Commission certified centers. The procedure, you would need the day, month, and year for which the principal procedure was performed. So if they were given IVTPA, then you need the date, time, month, day, year, and time that actually that IVTPA was given. And then you would code, the principal code would be the peripheral thrombolytic. So the principal procedure is the procedure that's performed for the definitive treatment rather than for diagnostic. So if you're doing, say, an MRI, just looking for a diagnosis, that's not considered a procedure code. But if you're actually doing a treatment to try to help resolve whatever the problem is, then you use the principal procedure code. And again, the allowable values, they use the CMS government guidelines, so there is a link there to that. So you can get those codes from there. Next slide, please. So this is our last slide, but just letting you know, when we had our December 11th update for the release for the PMT, all users for every one of the modules, whether it's stroke, stroke limited, the MER layer, comprehensive, any of the modules, we did do an ICD-10 code update. So because some of them had changed. So those have been updated in the PMT. And then the other thing is when you go in and look at the actual entry and you're looking at the code instructions, the coding instructions, there is a link in there that will take you to the existing tables that they have for coding instructions for the Joint Commission only. So there's a little box at the top that shows some of the codes or most of the codes that are used. But then if you actually want to look at the existing table, then you can go into that link that I showed you earlier for the Joint Commission manual. All right, next slide. I think that's it. Yeah, any questions about that? Any more questions? Okay, I hope that's helpful.
Lindsay's question was related to the interventions related to the TLC diet, reducing weight and increasing activity, for not being able to select those interventions.
Okay.
This is a known error for all those on the call that are having that same issue. We do know that this is an error. IQVIA is working on a solution to this right now, and it's slated to be fixed early March. So for those who are still having this problem, for now, go ahead and select save as incomplete for that record, and you will just go ahead and close out that record as incomplete. And then once the fix is in place, you should be able to go back and close out that record as completed in early March. It won't affect your data. You'll still be able to run the data for your measures. It won't hurt your data for your measures.
Yep, that's correct. Okay, so there's no further questions, then I'll turn it over to Allison, and we may have time for a few more questions at the end. So go for it, Allison.
All right. I don't think my stuff will take too long, so we'll go quickly. So I was asked to cover 5 areas in the abstraction that were falling below 95% when they were looked at for inter-rater reliability. And these are just certain data elements that were covered when they were looked at when the auditors came through. And we're going to go through these one at a time, and I'm going to kind of just touch on them and talk about where they are in the PMT, what are some key things you should be looking at in your EMR, what are some things that you can look for in the coding instructions if you're having trouble with them, questions you may need to ask if there's policy issues in your hospital that you need to address with relation to these key items that might help to shore up some of the confusion. All right, next slide, please. Oh, sorry, can we go back to the previous slide? Should probably mention what they are. These 5 items are arrival date and time, last known well date and time, CT date and time, NIH stroke scale done at this hospital, and then was the NIH stroke scale documented. All right, and next slide. All right, so the first one is arrival date and time. I have heard this before, that the arrival date and time tends to be a tricky one. For those who have heard this before, it's often called the door time. And if you've ever been surveyed by Joint Commission or DNV or any of the auditors that come through, the door time is a tricky one. Door time can be documented in several places. It's often abstracted differently. And so sometimes when people check inter-rater reliability, it can be pulled in different ways and in different places. So it's up to you to use your hospital's policy and to pick a time and a date that is consistent and to reference that consistently in what your door time is always going to be. And to stick with that, you know, to say this is always going to be what our door time is. This is the place in our EMR that we're always going to use. And kind of stick with that. I will also note that there is a place where it says admit date on here. The admit date is sometimes going to be different than the arrival date and time. And you can click on that, Kristen, go ahead. Yeah, the little boxes pop up. Yeah, that admit date sometimes can be a day later than the arrival date and time, because sometimes we know our patients will come in the ER and they may not get admitted till the next day. If you, for some reason, do not know the arrival date and time, I don't know, that probably doesn't happen too often, but you can select unable to determine. UTD. This is, of course, documented in military date and time. It is the earliest month, day, and year that you have documented in your patient record according to the coding instructions. And it's, of course, found on the admin tab. Do we have any questions on this so far? If so, go ahead and pop those into the chat box. I think this is a pretty straightforward data element. But of course, if you're having any issues here, please feel free to reach out to Kristen or I, and we'll be happy to discuss with you. This is definitely something, you know, if you're having inconsistencies in your data, to take up with your hospital team, with your stroke team, and to talk about, you know, what are we establishing as our door time, and to make sure you're coming up with a policy within your hospital that is consistent. All right, next, please. All right, so the next topic we're going to talk about is the last known well date and time. This one also can be a little tricky. This is going to be found in the hospitalization tab in the PMT. You can click on the first click, Miss Kristen, and the next click. It's right here at the top under the symptom timeline. This is the time and date we all know is the time and date at which the patient was last known to be without symptoms of their current stroke, or last known to be at their prior baseline. This one can be a little tricky, and this is also hard because there's a hierarchy found within the notes. We know that we can get last known well times from a lot of different people when it comes to the documentation. We can get it from the nurses, from the EMS folks, from different physicians, and so it's hard to know when you're the abstractor, who do I take it from? And so when you're looking at the notes, the hierarchy I have listed here is how you should take the last known well. If you have a neurology one, take that first. If you have an admitting physician, you can take that next. Then emergency department, then ED nursing, and then EMS. So if you don't have any of the above, take the next best. You know, if you don't have a neurology, take admitting. If you don't have a neurology or admitting, take emergency department, and so on. Hopefully that makes pretty good sense. Sometimes time of discovery will be the same as last known well. Sometimes it won't. If that patient was a witness stroke, time of discovery will often be the same. If it was not a witness stroke, sometimes time of discovery may be completely different. Time of discovery might be hours later. So click that. If you know it's the same, you can click that and it'll auto-populate that same date and time into the second box over to the right. Okay, I think that's all I wanted to talk about on that slide. You know, last known well can be tricky. It's just all about really, you know, talking to the patients, getting a good timeline, making sure you're doing a good, solid interview. This is it's a hard time to nail down. And I think it's something that a lot of practitioners struggle with, and it's hard to get the documentation for. So I can understand why this is a tricky one to get a good inter-rater reliability on. So that's, I do want to say that I think it's trending upward. It seemed like it was doing good. It's just, you know, we're not quite there yet. So I think the goal is to get it above 95%. So we're doing better. We just got to get it up above 95%. Next slide, Ms. Kristen. All right, the next one was to get the CT date and time. So with the Get With the Guidelines PMT, the goal is to get the initiation of the CT, not the time that it was completed. So this is a harder one because sometimes it's hard to find when it was started. And what I tell folks to do is to actually go in and find the time that's on the first slice of on the PACS image. For this one, I actually used an image. This is a CT head, not a CT brain, but that's okay. Anyway, this was a CT head without contrast. Sorry, I snipped out the bottom of it. It's a skull. And you can see I've circled up the top so you can see the time and date stamp, but that's where you're going to get that picture. You can get the time and date stamp so you can see where you're going to get that information that you need for what you want to input into the PMT. And if you click it again, it should pop up with on the hospitalization tab, you're going to be looking for this box right here that says date and time brain imaging first initiated at your hospital. So that's the hard part, is to get that first initiation time. And some folks may have different processes. I actually talked to some of the hospitals here when I was looking at how everybody does this. Some of the hospitals here have reports that their EMR generates that actually give them the first slice time. And so if your hospital does that, that's great. If that's how you can get that time, that's even better. I also talked to a hospital that has a little bit more complicated process because they have to call radiology, and radiology will sometimes have to push images to them, and we'll have to actually send them those times. So that takes a little extra time. It's more steps, but they in the end will get those dates and times. So it's just, every hospital is different. Everyone's got their own process. It's just a matter of how you get that, and is it in your medical record. So just kind of keeping that in mind. I don't know if I have any more clicks on here. I want to go ahead and click. There you go. I think I put that in here, checking your packs, specialized reports, just being consistent with where you get your data. That's it, I think, for this slide. Okay. NIH stroke scale done at this hospital, and then was it documented? So this is going to be on your admission tab in the diagnosis and evaluation section. You have, click it again for me, Kristen. In the middle of this section, you have a little section right here that says initial NIH stroke scale, yes or no. So you want to select, was it done? First of all, yes or no. So hopefully you're selecting yes. And then if yes, was it an actual, or did you estimate it from the record? If you are estimating, hopefully you're not estimating. Hopefully it was an actual. Hopefully it was actually performed. I want to, if it was actual, you can put the total score in the box right here below. That's even better. That means you were able to get an actual total score from the documentation somewhere in your EMR. But if you are able to, if you're having to calculate it yourself based on the documentation you have in your EMR, you can go in here. You have an NIH stroke scale. If you click on show, that's what that little red arrow was. Click on show. It will pull up a full NIH stroke scale where you have all these little handy dandy drop downs. And each of these will calculate for you. And once you do that, you can click on where it says calculate score, and it'll fill that in for you. So you could theoretically run your NIH stroke scale in here, and it'll calculate out your score. So that's another way to do that. I don't recommend that as much because I just feel like it's not as, you probably don't have as clean of an iterator reliability that way. So actually you're probably better off if you can get the physical actual score from your record that a physician put down or somebody that is certified. But if not, this is also an alternative. So that is from your diagnosis and evaluation section. Next slide, please. Just these are the notes from the NIH stroke scale section of your coding instructions. You should be looking for the first NIH stroke scale calculated or documented based on the first arrival notes in the neurology consultation note, or whichever comes first. So if you have an ER note that came first in the arrival notes, or if you don't have one there, if you got one in the neurology note, whichever came first. If you have a patient that got IV alteplase and they did not get an NIH stroke scale done, let's hope that they did. But if they did not, you should not be marking that they did get an NIH stroke scale. We've had that happen before. In fact, I think that was in our example that we did in our boot camp, that the patient did not get an NIH stroke scale done before they got alteplase, which is obviously a big no-no. Select not documented. The initial NIH stroke scale may be documented by a member of the stroke team or a nurse, a PA, an advanced practice nurse. It's highly recommended that this person is a certified examiner. So it's also, we hope that they're somebody that knows what they're doing and has at least performed this exam before. those are the key takeaways, I think, from the abstraction section for the NIH stroke scale out of the coding instructions. Obviously, there's quite a bit more. I kind of just pulled the key things. If you'll go back one slide, Kristen. If everybody remembers, if you look at these little blue headers on these sections, any of those in the PMT you can click on will take you directly to the coding instructions for that section. So if you're ever in the middle of something and you don't know what you're supposed to enter, or you don't know how to answer a question, and you're just totally lost and you have no idea, click on that and it will take you directly to that section in the coding instructions that will help you to answer that question. So it's a really easy, quick way to get to the right place in the coding instructions. That's my quick and easy answer for that. I think that's really it, Kristen. That's all I've got. If anyone has questions, have we had any other questions come back? Let's see. If last known without, let's see. Not a date, but a time range, wake up stroke, 2 to 3 days, 1 to 2 weeks. Just put that in a comment. Let's see, Robin's question is last known well time is not a date, but a time range, like a wake up stroke. Just put it in a comment. Oh, that's a good question. I don't know.
Can we change the drop-down option from date and time to just date? Is that what she's asking?
That might be a good way to handle that. Robin, if you're still on. Because I think in the coding instructions, it actually tells you to put the earliest date known that would be the possible, like the earliest date known of when they were last known well, if that makes sense. Like if they were last known well 2 to 3 days, you would put 3 days. Or if they were last known well 1 to 2 weeks, you would put 2 weeks. So then you would put whatever date that was. And so if that's the time, you would just put a date instead of a time. To change the format from a date and time to just a date. Does that help, Robin? I'm getting a smiley face from Robin. Okay. She says yes.
Well, yeah, I think they could also use it for the discovery, for the last known well time would be whatever time they went to bed or was last known to be well, and then the wake up time would be their time of discovery. So if it was the wake up stroke, right, you could do it that way.
Yeah. Yeah, I don't know if there's like a 2 to 3 days, but I don't know if that's really considered a wake up stroke.
No, it's within 24 hours.
Right.
And I'm taking it back to the slide to point out that when it asks for date and time, hours and minutes, if you don't have the hours and minutes, then you can select the drop-down caret and change it to just date if that's all you have. Right. So I wanted to point that out too.
Yes, you can do that. And those are typically going to be people that are way out of the window. Great questions, guys. We are right at the top of the hour, Kristen. I think we covered everyone's questions. It looks
okay.
Like.
Yeah, thanks everybody for joining us today, and we hope you kicked your new year off to a great start, and just reach out to me if you have any questions. Y'all have a great day.
Thank you, everyone.